Thank you. Good afternoon, everyone. It's nice to be part of the Michigan Mafia here. Dr. Jim Suchik in the back, who was present during my first anesthetic, my first day of my CA1 year. Mike Mathis, myself, Dr. Trumper, who I guess I'd make you the godfather, and several others who went to Michigan Medical School as well. So pleasure to be here with all of you. I want to thank Dr. Tan for inviting me and the organizing staff as well. It's been a really impressive conference today. I've had an amazing experience. It's my first one as well, like for many of you as well, and certainly will not be the last. I know that I'm the penultimate speaker. I'm glad they saved the best for last. I have 3 things that I want to talk about, hoping to be done in about 20 or 25 minutes or so. I'll leave time for Dr. Megan Lane-Fall and some questions as well. I know many of you are familiar with MPOG. I'll spend a few minutes talking about MPOG infrastructure to catch folks up for those that are not as familiar. Really want to spend the bulk of my talk on our methodology for multi-center QI. MPOG does a bunch of other things. For the purposes of this panel, we'll talk a little bit about QI, and then finally want to highlight some challenges and opportunities, hopefully to set us up for a robust discussion afterward. I'd love to hear some thoughts from folks in the audience about things that you consider to be opportunities or challenges for MPOG as well. My disclosures, I don't have any personal relationships, but my institution does receive funding on projects for which I am either a PI, co-I from several different sources, including Blue Cross Blue Shield of Michigan, from which you heard earlier from Dr. Grant, who I think is now on a plane. MPOG infrastructure. As many of you know, MPOG has a dual mission of research and QI, founded 15 years ago by Dr. Trumper and Sachin Ketterpal, really to help conduct multi-center observational analyses, initially for sites that had GE's anesthesia product centricity, and later, subsequently, in around 2014 or so, the same folks started to realize that, hey, this data can be used for quality improvement as well. 15 years or so later, we're about 80 or so now hospitals around the country. We have a cluster of 35 hospitals within the state of Michigan, primarily because of the support we received from Blue Cross Blue Shield of Michigan, and we'll talk a little bit about that later as well. MPOG aggregates data from a range of data sources, primarily the electronic health record. We grab the minute-to-minute physiologic data from the monitors, laboratory and diagnostic data, clinical care data like medications administered, inputs, outputs, staff information, intraoperative events, administrative data like discharge diagnoses and pro-fee billing codes. We also integrate or connect with registry data as well and have a separate pathway for that, both at the local level with registries like NISQIP or STS, and at the coordinating center as well with registries like MSQC or MBSC, which are some of the other CQIs that you had heard Dr. Grant talk about earlier. Most of the minute-to-minute physiologic data is the immediate perioperative period. So about 4 hours before anesthesia start to 6 hours after anesthesia end. I think that highlights already some of the opportunities as well as some of the challenges and limitations of MPOG. MPOG is structured in a very specific way. Fundamental premise of MPOG is that the data is owned by and controlled by the institutions who participate in it. The source data is extracted to a database that exists within local sites or local institutions' firewall. There's processing done at the local institutional level, including the removal of PHI, except for data service. It's called a limited data set. And then that data is transmitted to the coordinating center, currently the University of Michigan. That the data then lives within U of M firewalls, where MPOG conducts a bunch of computational analyses. We'll talk a little bit about that as well. And then, we use it for quality improvement. We use it for observational research trials. More and more, it's being used as the platform for pragmatic clinical trials and other things as well. But the fundamental storage and computational analysis occurs within the Michigan Medicine firewall, within Michigan Medicine data centers, and then is then shared back with our sites in a limited data set format. The approach for MPOG, so the slog of MPOG, the dirty work, the hard work that's been done over the last 15 years is taking raw EHR data and turning it into usable information. So we take variables like medications administered, like the minute-to-minute blood pressure information. We asked our sites to conduct validation on that data using some specific tests that we call data diagnostics or case-by-case validation. And then when they sent it to us, we do some additional testing on it, some additional computational work on it that we call collation mapping or answer mapping. We build digital phenotypes or computed phenotypes, which I'll describe in a little bit more detail. And then once we take that raw data, the bricks, build it into walls, then we can build houses, which we call performance measures and other usable clinical data. That process started a decade ago with maybe our first dozen or so phenotypes. Now we have about 500 phenotypes. It's really what makes MPOG data usable. It's really the hard work that's being done at the local site level to ensure that clean data is being sent to MPOG, and then by our coordinating center team to ensure that that validated data is turned into actual usable digital phenotypes for both QI and research. So one example, I stole this slide from Mike Mathis. Another way of looking at it is that raw EHR data like ICD codes, like lab information, like demographic information, professional billing information, laboratories, other testing, that kind of stuff gets computed, that kind of stuff gets organized in a bunch of different ways to then turn out information like, was the patient under a general anesthetic or was it a MAC or was it a regional case? It lets us know what the baseline blood pressure is. It lets us know, for example, when bypass happened. What's super interesting is that if a person were to look at an individual electronic health record, it's pretty easy to determine some of those things by sifting around the electronic health record. But asking a computer to do it across 80 institutions, across every single case, millions of cases now, tens of millions of cases now, takes a lot of not just computational horsepower, but actually takes a fair amount of work at the coordinating center to design the computer algorithms, design the specifications for the algorithms to make sure that when we build a measure which excludes cardiopulmonary bypass times, for example, or excludes cases for patients who underwent cardiopulmonary bypass, we do it accurately. And really that, I think, is what makes, from a data perspective, MPOG. We'll talk about some of the other things that make MPOG in a little bit, but from a data perspective, it's really this validation, this cleaning of raw data into usable digital phenotypes. A classic example for us that we share over and over with our sites is something as simple as ASA class. You would think would probably be 12 different values, ASA 1 through 6, E or not. If you look across our all the hospitals in MPOG, all of our institutions, there's actually 4,120 different ways in which ASA class is documented. And so we do the work on our end to turn that into those 12 values that we are all familiar with. And then multiply this by the 1,000 or so variables or concepts that we import from any given site. And you get a sense of some of the work that happens at the coordinating center. So that's a little bit about MPOG infrastructure. I'll spend the next few minutes talking about our QI methodology. Pillars of MPOG QI have not changed over the last few years, built on the QI measures that we've developed from these digital phenotypes. We now have about, this is a little bit over 60 plus measures, multiple anesthetic domains of care, both process as well as outcome measures. We benchmark them as part of our feedback mechanisms, both nationally as well as locally. At the practice level, we provide individual provider feedback, typically monthly, that's benchmarked locally. And we try and link measure performance to the actual case. I'll talk a little bit about that in an upcoming slide. The quality committees are the primary governance mechanism of what to do and how to do it. They provide a check step. They provide feedback, guidance, best available evidence or expert consensus as well. Those committees meet at various times across the year, both in person and virtually as well, and comprise both our Michigan sites, so our cluster of sites in Michigan, as well as our sites from around the country as well. And then finally, an implementation component as well, where we take bundles of performance measures. We take what we know about implementation. I'm sure we have a lot to learn from folks like Dr. Lane Fall and others about implementation science, but we take what we know and what we have, and we build toolkits. We visit sites, especially within the state of Michigan, to learn from them about how they've used MPOG QI measures and how they conduct their QI projects. And then we have some programs as well that we've launched in concert with Blue Cross Blue Shield to provide some financial incentives for sites within the state of Michigan. Measure building typically starts with an idea generated from one of our sites, from one of our anesthesiologists or our CRNAs, from one of our subspecialty committees. Those measures then get discussed at our quality committee, and then internally at the coordinating center, we'll come up with a measure specification. We'll detail the rationale for the measure based on feedback from the quality committee, inclusion and exclusion criteria, markers for success, thresholds, limitations of the measure, and then that measure would then be approved by the quality committee by a vote. Majority vote typically signals for us that we should go ahead and build the measure. The measure building is done at the coordinating center level. So we have teams of nurse informaticians, statisticians, data scientists, project managers, faculty, who work together to build the measures based on feedback from these various sources. We test it and refine it. We do the validation for it. Many times we reach out to folks at your institutions who are members of MPOG to help us with that data validation, and then we publish it to our dashboard and add it to our provider feedback emails based on the direction from our sites. And we rinse and repeat. And this has really been our measure building and publication methodology. Importantly, all of our measures are reviewed at least once every 3 years. So every 3 years, we have a process in place to review measures, make sure that it reflects the best available evidence, either modify the measure, keep it as is, or most importantly, retire it if it no longer applies. And as we talk a little bit about some of the challenges that MPOG faces, we'll talk a little bit about that process as well. So as I mentioned, we have now over 60 process and outcome measures over a variety of anesthetic domains. They initially started in highly clinical domains like glycemic management, neuromuscular blockade, blood pressure management. As MPOG started to get more data related to patient outcomes, we started to build measures related to mortality, PONV, and then as the subspecialty committee started to become really engaged, we started to build measures along subspecialty lines like OB anesthesia, cardiac anesthesia, pediatric anesthesia, which has a very robust program. And then more recently, moved into population health measures as well, either from national experts like Jody Sherman, who gave a talk at one of our MPOG retreats a few years ago and kind of inspired us to build out a sustainability bundle, or sometimes the payer, Blue Cross Blue Shield of Michigan, which had a statewide focus across all of the quality improvement groups on smoking cessation and smoking cessation counseling, asked us to build some measures related to smoking cessation in the perioperative time period, and we did it in concert with them as well. So it really crosses a range of different anesthetic domains, a range of different population and public health measures. That is one of the opportunities when you have a really broad data set. It's also one of the challenges. Focus, continues to remain a challenge for us, and it's one of the things that we, I think, are looking for guidance on and a position on as we continue to grow. A core part of MPOG QI is the individual clinician level feedback, and this is an example of our monthly feedback email that I get, that many of you get around the country. We send it to about 8,000 folks or so around the country on a monthly basis. It's typically reflects last month's cases. It's meant to serve as a link between your performance and the case that went into causing that performance. And so if you click, as an example, if you click on this train of 4 measure performance, you can actually get to MPOG's representation or MPOG's version of the anesthetic record. And the thought is that you could take that measure performance and look at the case to see how you arrived at that measure performance. And the philosophy is that looking at the actual case is that moment of practice reflection, and potentially can cause practice change if needed, or can also be an opportunity to let your quality champion or MPOG know that something is wrong with the data, for us to be able to fix and look at from a data quality perspective. And really, like, understanding or enabling clinicians to understand why cases did not pass a measure, I think, is the kind of fundamental component of the individual provider feedback level. Also, lucky enough to have participate in a program with the ABA to enable MOCA or award MOCA credits for following this process as well. And so trying to have multiple uses. At the practice level, quality champions, quality leaders, practice leaders can use this as a snapshot to look at departmental performance across the range of measures that MPOG builds. You can also use it to look at outlier cases as well. So you're able to drill down at a specific case level or at a specific provider level as well, to be able to see outliers or exemplars in your institution as well, and to enable either QA or QI projects. The same benchmarking, similar benchmarking that's available at the provider level locally is available at the national level institutionally. And so for practice leaders, we show them a institution's performance on a measure compared to all the other institutions within MPOG. We can also show them performance comparisons within an institution as well. So if you want, for example, at Michigan, we can show performance at different locations across the University of Michigan health system. And because we have a broad data set, we can do interesting comparisons, like for example, the variation in use of sugammadex and neostigmine across MPOG sites. This was the result of a question from one of our sites a couple of years ago, and so pretty quickly we were kind of able to almost kind of stunningly see that there was really wide variation in the use of sugammadex and neostigmine. I think this was 2022 data, maybe about a year and a half or so ago, where across MPOG sites, still had a bunch of folks that were primarily on neostigmine, also had a bunch of folks like Michigan that were primarily on using sugammadex as neuromuscular reversal. So you can do kind of some interesting analyses with the data that we have. So I will toot the horn of some of our Michigan sites. I did want to share some of the work that we were doing within the state of Michigan as part of the CQI program. this is one example. So we built a measure looking at temperature outcomes or hypothermia in our patients several years ago. We released that measure nationally in 2 on Michigan sites. We discussed it at our statewide quality committee meetings that Dr. Grant had talked about earlier this morning. What's super interesting, Mike alluded to this as well in his talk and in the panel discussion afterward, is that the data is necessary with these meetings, but it's not sufficient. And so what you actually need to make any progress in any quality improvement initiative is trust and collaboration. Multiply that like 10-fold if you're doing it across centers, and 100-fold if you're doing it across competitors as well. And so over the years, we've had to build in systems where folks, you have to drop the fact that Beaumont and Henry Ford are each other's throats at the competitive level, at the institutional level, but at the provider level or the, at the anesthesiologist CRNA level, we are just trying to take better care of our patients. Establishing that culture and the mechanisms for that, I think, has been, maybe the hardest part of what we do, what we've done within Aspire, within our state of Michigan group. But you can look at some, kind of, I think, some pretty impressive statistics for like cutting the rate of post-operative hypothermia in half. This is all unpublished data that we shared a few months ago at our meeting. If you look at adherence to our hyperglycemia measures, you can say, from 60% to 80% over the last 8 years, slowly over time, seeing increased adherence, even with the addition of new sites to the treatment and management of hyperglycemia. If I look at measures that you think would be very rare events, like not giving a reversal agent, you can see kind of slow and steady climbing of and improvement in performance with things like the appropriate administration of reversal agents. And then, excessive tidal volume administration, again, even with the addition of new sites each and every year, you can see the message has gotten out through the dashboard and through the collaboration. I will say there are other measures which we haven't shown any progress in at all. Of course, I didn't include those in this talk, but if you look at, for example, our blood pressure measures, those are ones that, for interestingly enough, even with a lot of focus and a lot of publications in the literature, we really have shown, kind of marginal improvement, if any, performance across our collaborative over the last few years. And then finally, I just want to highlight a couple of challenges and opportunities. This is by no means exhaustive, just kind of scratches the surface of some of the things that I thought of as I was thinking about this talk. I think, our biggest opportunity and challenge is in systems in groups like the CQIs. Blue Cross of Michigan has been a great partner for us in helping to fund infrastructure at both the coordinating center level, but most importantly, at the institutional level. So, what institutions around the country pay for or have to self-fund, Blue Cross Blue Shield of Michigan funds for hospitals within the state of Michigan. It's really, been amazing at lowering the activation energy needed. It represents, honestly, only part of the cost to be able to join, but even that, partial funding has proven to really, really grease the wheels in terms of joining a group like Aspire or MPOG. And as Dr. Grant mentioned, there's been a lot of evidence to show that these CQIs have been successful, and we've really glommed on that. We've really used that to engage our sites within the state of Michigan and to have providers become really active members of MPOG. There's 2 programs within that. One is the P4P program, and the other is Pay for Performance, and the other is VBR, value-based reimbursements. Those are both incentive programs that we co-administer with Blue Cross Blue Shield. So Blue Cross Blue Shield provides funding either at the hospital level or at the provider level. We use charts like this to award points to institutions within the state of Michigan for either showing up, coming to the meetings, or for improvements in quality based on pre-specified quality measures. And based on performance, they can get either hospitals or sites can get anywhere from 2 to 7% uplift, which in a low margin hospital environment can make a big difference. Now, the opportunity is that money talks. When you throw dollars and you show dollars at something, it definitely grabs attention. There is a downside to that as well. We sometimes the discussions, instead of being about the implementation science or quality improvement, end up being about minutia around measure specifications, because folks are worried that they're going to either have a measure be flagged or not passed because of some issue which may or may not be relevant. And sometimes kind of getting involved in that minutia makes you kind of lose sight of the bigger quality improvement picture that you're trying to relay. All things considered, I think both of those programs really has helped us focus on specific quality improvement efforts within the state of Michigan. I think replicating that across other states, I think would be amazing progress from a perioperative quality improvement perspective. We've launched a study with Dr. Zach Landis-Lewis et al., funded by the National Library of Medicine, on precision feedback. And so this is to take the standard MPOG email, add in feedback specific to a provider's preferences, or add feedback specific to a provider's performance. This is about to launch a pilot cluster randomized pilot trial, and then a full cluster randomized trial next spring. And it's really to gauge if this software-enabled precision feedback service can improve compliance with measures. I think really exciting component from a feedback perspective, and hoping that MPOG can really learn from this project to really take our provider feedback to the next level. And then, I wanted to throw in a couple of challenges. I think a big challenge we have is measure fatigue. With 60 plus measures across a bunch of subspecialties, folks, providers, we've talked about provider burnout earlier, getting a dozen measures that you're graded on every month, having practice leaders look at, dozens of measures on their dashboard is a lot of work, and takes a lot of mental and emotional energy to process. I think, at MPOG, for every one measure that we've retired, we've probably built 10 measures. At some point, that ratio needs to get a little bit smaller. I think we need to think about, just because we can build a measure, should we? And then, I think the types of data that we have, in many ways, we're very accurate. Are we hitting the right target? Should we be focusing on things like patient-reported outcomes or clinician-reported outcomes instead of data from the EHR, which has been our mission, our sole mission over the last decade and a half, are some of the things that we need to think about. There's been some evidence to show that compliance with measures improved compliance with measures after the implementation of feedback occurs, but I think there's other evidence which shows that sometimes the measures are ignored, and so we need to grapple with that as well. And then finally, I want to just briefly discuss I think a major new opportunity, and that is using MPOG data to improve the experience of both learners and experienced physicians. And so I'm talking about anything from a basic assessment of the learner experience, what types of cases have learners or physicians or CRNAs been involved in. Are you seeing the right types of cases as a resident? You don't want to leave residency not having managed massive resuscitation, or not having managed a number of difficult airways. How do you know that providers are getting that experience? I think using MPOG as a platform to ensure that, to expose that, I think will be a huge opportunity. And then taking it to the next step of competency-based training. If based on what MPOG knows about a provider's performance, someone mentioned that earlier in a question. Can we target education? Can we target training based on specific knowledge gaps that we know a provider or an institution may have. Just a couple of thoughts. Would, again, love to hear from others about how they feel and regarding any of these opportunities and challenges. And with that, I would like to conclude and thank you all and hand the mic over to Dr. Elaine Fall, and looking forward to the question and answer session in a few minutes. Thank you.